Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. You're invited to join us on air, asking your questions by calling in on the local rate phone numbers in the UK and the US, which can be found on ldnradio.org. Thank you for joining us. Today we're joined by Dr. Leonard Weinstock, and he's going to be talking to us about GI conditions. I can tell by the number of emails that have come in that many of you are going to be very interested in this show. So thank you, and we will start very soon. Full details of the 2017 Integrative SIBO Conference and Professional Forum on Saturday and Sunday, March the 25th and 26th in Illinois can be found at www.synergy.com/2017-integrative-SIBO-conference. We hope to see you there. Thank you. And Dr. Leonard Weinstock is from Missouri in St. Louis. I like to say Louis, and he always corrects me. I think it's quite funny. So thank you for joining us today.
You're welcome.
Thank you. Would you like to tell us first about you, your practice, and what you have been doing before you started using LDN?
Okay. Well, Linda, I've been in practice since 1987 and graduated a very conservative institution, Washington University, for my GI training, and joined a very innovative doctor who always encouraged research and education and change. And that's what he was all about, and pretty much what I grew up with. But I had to break from the mold, and the thing that really changed everything was a whole new look at irritable bowel syndrome in 2000, when the role of bacteria was discovered in irritable bowel syndrome. And then another game changer, as we like to say in the LDN business, is being introduced to it in 2005 by a compounding pharmacist who came over to the office and said, you know, you might be interested in this compound. There's not a lot known about it and with the GI tract, but you could use it. And I have difficult, challenging, interesting patients and come to me for second and third opinions, and indeed, anything new, any new trick is something that I was interested in.
Mm-hmm. That's really interesting. So when you first started prescribing LDN, how long ago was that?
12 years now.
12, okay.
And it was primarily for gastrointestinal motility disorders. And then as I learned more about the anti-inflammatory properties, I applied it to inflammatory bowel disease. And then later on, I applied it to some of the extra-intestinal manifestations of GI disorders that I took interest in, such as restless leg syndrome, rosacea, chronic pelvic pain disorder, etc.
Mm-hmm. And we're very pleased and proud to have you as one of our medical advisors. I think you're one of the hardest working doctors I can think of. You try so hard for your patients, which is amazing. And from those patients that you have prescribed LDN for, what side effects have any of them reported? I know that you keep track of these things.
Well, I do, and for a new drug, I decided to actually look at what the side effect profile was it's because this is something we were never taught in medical school or fellowship or residency, and likewise, compounded medicine is something that was pretty much unheard of in general medical practice. So I looked at in 2010 my experience from 2005 to 2010, and looked at 120 patients. And anxiety was number one. So I actually grouped it into neurological side effects, GI side effects, and other. So anxiety was in 15%, drowsiness 11%, headache 11%, dizziness 10%, insomnia, muscle pain 8%, vivid dreams 5%, mood change 3%. And then surprisingly for GI side effects, and of course this could vary in terms of interpretation, since many of these were IBS patients who tend to have bad symptoms from any medication. Nausea was 12%, abdominal pain they thought was worse in 11%, diarrhea in 8%. And then very, very rare was a rash, hot flashes, or weight gain, all in the 1 out of 1,000 or 0.1%. So when I start patients on the medication, I do warn them that insomnia, anxiety, and vivid dreams are reported to be the most common. And I found that half of the patients who get those will get better in time, or will get better with dose reduction or changing of the time that it is administered.
Mm-hmm. What percentage of patients would you say have side effects?
Well, we looked at that too, because those are a whole list of things. And in this study that was published, it's interesting that 61% of the patients had side effects.
Really?
Yeah. So it was common. But again, who were these patients? Most of them were irritable bowel syndrome patients, some with chronic constipation, but that was, when you look at any drug study that's placebo-controlled and blinded in irritable bowel patients, there is generally a high side effect profile. But, I've used this drug in other patients, those with autoimmune conditions, fibromyalgia and MS, rheumatoid arthritis, complex regional pain syndrome, and there is some spillover, and I think the incidence of side effects, however, is a little bit higher in the IBS patients, but I do believe they're real, but I think possibly because of their autoimmune condition in some, that it's worse.
Okay. So of those 65% that had some form of a side effect, how long did that last? Did you check again if they had side effects, say, a month later, or wasn't that in your study?
Yes, I did. Yeah, so most of them, 32%, had short-lived symptoms. It went away after a month or so. And then, however, in this particular study, 20 of 74 patients did terminate LDN. Now, that's different than my Crohn's patients, where 15% terminated because of insomnia, and also my restless leg syndrome study, where another time, once again, 15% had to stop it because of side effects. But we're talking about a potent medication. It's a little medication in little doses, but it does increase endorphins in the brain, and that is significant. Endorphins are powerful chemicals, and so one has to appreciate the fact that some people just can't take it.
Mm-hmm. So for those people that terminated, did you first try reducing the dose and the time of the day before they terminated?
Well, in 2010, I did not. But now what I'm doing to decrease the likelihood of side effects, I'm starting at either 1 or 1.5 milligrams and trying to do the nighttime dose, which, dovetails when endorphins are normally produced in the middle of the night so that the LDN binds to the receptors, and then it comes off in 4 to 6 hours when the circadian rhythm is such that endorphins are normally produced at 3 or 4 in the morning.
You know what I'm going to ask, don't you?
Some of the lower doses, I think it's better, and multiple people on support groups will endorse that. When they had trouble, they went back to 1 milligram and slowly worked up. Or in the case of people with autoimmune conditions, even starting at 0.5 and work up slowly, they do better.
Mm-hmm. That's what I was going to say. Things have changed a lot since 2010. And over here in England, at that point, people were starting on 3 milligrams, then in a month going up to 4.5. And that dose was too high for people, and we did get a lot of people dropping out. But as you say, by starting on a very small dose and increasing it gradually, the people with side effects has radically dropped. Have you found that in your practice?
Definitely. So these numbers that I gave out, I think we're seeing less of it.
Mm-hmm. Okay.
Definitely less.
Well, I have one question that a gentleman is dying for me to read out, and his name is Simus, and he says, I have a question about ITP and LDN. There are some anecdotal reports by people with other conditions of getting worse, like thyroid antibodies going up, etc. I have Crohn's disease and would like to try LDN, but I have mild ITP plus minus 90 PLT, and I'm afraid that it could make things worse with potentially serious consequences. Also, it appears that my Crohn's symptoms increase, fatigue, weight loss, pain, when my platelets go down as well.
Well, that's a great observation because ITP is considered one of the extraintestinal manifestations of inflammatory bowel disease based on the autoimmune co-association. And it may be that as the bowel activity gets worse, the things that trigger autoimmune antibodies also gets worse. And there was actually a nice report in Postgraduate Medical Journal that goes over a case report and has a nice clinical review. So if he wants to Google thrombocytopenic purpura or ITP and Crohn's disease, he'll come up with this nice article. And in that article, it talks about a difficult management case where immune suppressors were used. And what LDN does, of course, is it regulates the immune system. It controls and regulates the T cells, which trigger the B cells' production of autoantibodies. Animal models also show a change in the B cells with LDN. And one will say that many disorders get better with treatment of the primary problem, but many patients improve with LDN for not only the Crohn's or ulcerative colitis, but the associated conditions. So I would not have fear that treating with LDN would worsen the platelet count. I would think it would get better. But of course, there are really no reports on that to my knowledge.
Okay. Well, we'll take a quick break and then we're going to come back and we're going to talk to Dr. Audra Meehan, who's going to tell us about the SIBO conference where you're going to be a speaker at, which is really exciting. And we'll be back in just a minute. Full details of the 2017 Integrative SIBO Conference and Professional Forum on Saturday and Sunday, March the 25th and 26th in Illinois can be found at www.synergy.com/2017-integrative-SIBO-conference. We hope to see you there. To listen to individual radio shows and interviews, go to www.mixcloud.com/LDNRT. I'll repeat that. It's www.mixcloud.com/LDNRT. Welcome back. We've got Dr. Leonard Weinstock here with us, and we're going to be joined by Dr. Audra Meehan. Hello, Audra, are you there?
I am here.
Wonderful. Would you like to tell us about your up-and-coming conference? It sounds really exciting.
I'd love to. It's the first major conference being put on by Synergy CME Resource Group. We are a nonprofit independent medical organization that's dedicated to the development and presentation of continuing medical education. Mm-hmm. So our major platform in Synergy is to look at medicine from an integrative perspective, and we decided to approach small intestine bacterial overgrowth with that integrative perspective so we could put on a pretty comprehensive conference for people who are interested in that topic. So we have almost 24 sponsors. We have 11 speakers coming from all over the world. They have multiple specialties and backgrounds. So some of the topics that are going to be approached at this conference include we've got rheumatology, dermatology, nutrition, genetics, restless leg syndrome, diabetes, genetics, MTHFR, and then, of course, there's going to be some discussion regarding treatment, pharmacological protocols, and some of the research that's going on in the field right now. So the conference itself is taking place March 25th and 26th in Lombard, Illinois at the National University of Health Sciences. And it's going to be pretty spectacular.
Wonderful. What is your talk going to be about, Dr. Weinstock?
What was that?
I was asking Dr. Weinstock what he's going to be talking about at your SIBO conference.
Oh, it's going to be restless leg syndrome and going over my studies in rosacea. Mm-hmm.
So it's going to be a really heavily factored 2 days by the sounds of it. Really well worth going to. People will learn a lot. Is it aimed just at the medical professionals, or is it open to the public as well?
You know, we have decided to open it to the public. People have the option of attending either live, or you can attend by webinar, mm-hmm. which makes it available to people from all over the world. Because we found that this is really a topic that's of heavy interest in many of the countries that are out there, if not all of them. And so we'd like to make this as available to people as possible. And while I think that, you know, some of the terminology that's going to be used in some of the presentations will be geared a little bit towards professionals and physicians, it's still, for people who are looking for answers and more information, I think it's pretty digestible for the layperson.
Well, we wish you every success, and thank you very much for coming on to tell us about it.
Absolutely. Thank you for having me.
Thank you. Right. Well, we will have some more questions. We've got so many here. It's really exciting. And Jill Brooke has sent you a question as well. And she says, Dr. Weinstock, You've written about the intestines having cleaning wave several hours after eating, which is important for intestinal health and good bacteria, but it requires us to go several hours without eating. If I drink soup broth or soy milk between meals, will this prevent this cleaning wave? And how many cleaning waves should I have every day? And thank you.
Okay, so the migrating motor complex is that intestinal sweeper, as we like to call it. And really the most important time is at night, when of course you're not eating. So every 90 minutes when you're not eating, you're having this powerful wave start in the stomach and go all the way down through the small intestine, and that keeps it clear so we can absorb foods the next day. With respect to eating, at 8 o'clock for breakfast and then waiting to noon, does it really make a difference that, 90 minutes later, if you're fasting, you'll do better? Well, a lot of it depends on your own physiology. Part of the really exciting thing that has come about in irritable bowel syndrome is the knowledge that the migrating motor complex, that cleaning wave, is disrupted, damaged, and reduced in the majority of patients who have irritable bowel syndrome with diarrhea in the setting of small intestinal bacterial overgrowth. And it's due to autoantibodies that have formed from having had some kind of infection, such as a bacterial infection, which then triggers a series of autoimmune responses. And that damages the neurological mechanism. Well, if the neurological mechanism's damaged, it really doesn't even make a difference, what you do or don't do. The problem is there, and usually medicine is required to stimulate it.
I'm just thinking, I know there are doctors out there that tell people if they feel nauseous during the day to graze throughout the day. Is that a good idea for your gut health? Should we be waiting longer in between eating food? I mean, I know Jill mentioned broth there, which obviously the body would see as food. My understanding is if it's got any protein in it at all, even soy milk, it's classed as a food rather than a fluid. Am I correct? Okay.
Correct.
So should we be...
Except that clear liquids often go through the stomach very quickly, and probably through the small intestine fairly rapidly. It's the fat that slows things down in normal people. And then, but for people who just have to get the calories in, I don't say don't eat between meals just because you might get a little bit better wave motion. I'd rather just treat the underlying condition aggressively. Okay.
Oh, that's interesting to know. All these different things to learn about your intestines. I mean, we learnt from the last conference that what was said that the gut was the second brain.
Well, there's a lot of serotonin in there, more than the brain.
Wow. There we are. We have a question here from Rachel, and she says, "Hello, Dr. Leonard. I've experienced constipation since my teens, and I'm now in my 40s. Last year, I got to a point where I'd had enough. The doctors referred me to my local hospital. Some foods make my IBS worse: apples, garlic, sprouts, cabbage. I have tried the FODMAP diet, and this helped for a short time. I'm now on medication to relax my bowels and Laxido to soften. I still have experience with bloating, stomach pains, and generally uncomfortable. Is there anything else I can do? I believe I have not officially been diagnosed with IBS." She says, interestingly enough, my father experienced problems in the bowel area and he was diagnosed with celiacs. He follows a strict diet and he still has problems. Could this be hereditary or stress-related?
Okay, all very good. So irritable bowel syndrome, we're going to be spending a lot of time talking about that at the conference in September. so people can join in by webinar for that. But basically, it has to be abdominal discomfort as a primary symptom, and then associated with change in bowels and bowel form, in this situation with constipation, hard stools, and straining. Now, if it is, let's say, a problem with bloating, and then you have to worry about the addition of small intestinal bacterial overgrowth with methane production, or dysbiosis with methane production from the colon by too many methane-producing bacteria. And methane slows the colon down, and when methane bacteria digest FODMAPs, the indigestible sugars and carbohydrates, they produce a factory of gas, and they, ferment. And so that can be the bloating, bad odor to the gas, bad odor to the breath. So that is something that should be sought out. So when somebody tells me, well, they followed the FODMAP-free diet and they got better, but incompletely, then I say, okay, we need to do a breath test and see what the hydrogen and methane producers are doing. So I think that's something. Celiac disease was asked about in that question, and we do see it in constipation and bloaters, and not necessarily the classic diarrhea patients. Celiac disease can present with extraintestinal manifestations, anemia, 9 different neurological conditions, including restless leg syndrome and migraines, bone fractures. It's an amazing condition. Thyroid disease can be the first manifestation. So you do need to look for it. So any gastrointestinal disease that has not been figured out, I always do the antibody test for celiac.
Mm-hmm. When patients come to see you and give you all their problems, do you recommend any special diet?
So with my Crohn's disease, ulcerative colitis patients, I do recommend the specific carbohydrate diet, breaking the vicious cycle. A number of my IBS patients I will try on a gluten-free and dairy-free diet initially while we're starting the workup and evaluating what's going on. And the IBS patients also can get better from FODMAP-free, and then they can loosen up with it in time. Or if they've got small intestinal bacterial overgrowth or SIBO, I'll put them on a FODMAP-free diet for the first month and then gradually introduce foods, but always keep them away from corn syrup, fructose, corn syrup, and Splenda.
Is sugar a problem? I know you've listed there artificial sweeteners.
Yeah, It depends where the bacteria live, Linda. If they live up high, then even table sugar can be a problem early on until you treat them. But most table sugar is absorbed in the first 3 feet of the small intestine. So if the bacteria load is in the small intestine, let's say in the middle or the lower part, then we don't need to worry about it too much.
Okay. We had a caller, but she's gone, but she's left the question with Helen, and she said her daughter has IBS and she's on conventional medications. Her daughter is 11 years old, weighs 65 pounds, and she's concerned about the dose for a child given her age and her weight. She's taking 2.5 milligrams and wonders whether it's okay to combine both LDM with conventional medications.
I do it all the time, both in inflammatory bowel disease and irritable bowel syndrome. So LDN, I think, is a safe addition. As far as irritable bowel syndrome, I think it plays a role in several different mechanisms affecting the hypersensitivity of the intestines. There are numerous points where either reducing inflammation or adherence to the toll receptors can block neurological pain. So I think that's important. In inflammatory bowel disease, we definitely see patients who improve when LDN's added to biological therapy. You get a partial response to infliximab or Remicade, and you add the LDN, and people can get significantly better.
Mm-hmm.
I will say that if you look at Jill Smith's papers on inflammatory bowel disease, Crohn's disease, she does have a nice paper on pediatric Crohn's, and they were taking adult doses.
Mm-hmm. Okay. Well, that's interesting. Well, we have some more questions here. We've got one from Candace, and she says, Dr. Weinstock, I started LDN 2.5 months ago. The typical dose is 1.5 milligrams for 2 weeks, 3 milligrams the next 2 weeks, then 4.5 for a month. I started while in a UC flare and have not seen any marked improvements. I also have Hashimoto's, and my labs for that have come back normal. I don't know if I can contribute this to the LDN or not, since my UC has not responded. My gastro has me on biologics. If the LDN was going to help me, would I have seen this by now? Is there anything around dosing that I can do different? Thank you for your time and help. I want LDN to save me from biologics.
Okay. Well, first of all, I tell patients it takes 2 months to work, and pretty much any inflammatory bowel disease medicine can take that long, especially when you're changing the immune system. I mean, if you look at a patient's colon when they're actively inflamed, it's a mess, and it takes a long time to normalize things. And during that time, it's not you're not able to absorb things well, digest things well. It takes time for the mucosa to normalize. So, I say you have to wait 2 months. And
she's actually been on it 2.5 months now.
2.5 months,
yeah.
And then make sure again that it's switched from, if it's taken in the morning, switch it to bedtime. I've had a patient with restless leg syndrome and irritable bowel syndrome, and she was taking herbal antibiotics for her recurrent restless legs, her recurrent SIBO, and she was juggling so many pills that she accidentally started taking the LDN at night, and had a dramatic response to the restless leg syndrome, was dramatically better by switching it. And that, again, underscored to me the importance of working on a nighttime dosing. So I've really pushed that back again. I kind of shied away from it for a little while just because of complaints of insomnia. But then again, I was guilty, I think, of starting with higher doses in the earlier years. So lower doses, using it at night, gradually working up, understanding that it takes time not only to kick in, but to heal the gut, and that there's simply very few patients who do exceedingly well with one medication with inflammatory bowel disease. To get somebody in remission, it takes the kitchen sink sometimes, and then you back off on medication.
So with ulcerative colitis, what other remedies do you use? Do you just use pharmaceuticals, or do you use other supplements?
So there's 2 probiotics that have been studied. The best evidence for efficacy is with one called VSL number 3, V as in victory. Mm-hmm. So that's something that I'll use. I'll use the diet, the specific carbohydrate-free diet, and when somebody's really inflamed, I'll put them on a very low residual diet and gradually work up, because if it's inflamed and spastic, it's swollen, you're not going to get by with raw fruits and vegetables. As far as medications, I do use all the standard medications, and I do use biologicals freely for patients with severe disease.
Hmm. Do you find over time with LDN that they can reduce those other medications?
So if somebody jumped to biological therapy, I generally tell patients it's usually a lifetime commitment. And studies have just shown that with 1 year off, they 20% will flare each year of this study that looked at 2 years. So, after 2 years, you're going to have a 40% chance that you flared. If you were that bad to require biologicals in the first place, it's not good to go through a flare because you risk having surgery, and the surgery is not a panacea.
Mm-hmm.
So, bad disease needs aggressive medications. So I will pull away from immunomodulators like pyranethol, and I presented some of that data at the conference last year, and following these patients along to see if LDN can take place of mercaptopurine in time, and hopefully that'll be the case. But somebody's doing well on one of the 5 ASA medications, which are the standard building blocks to go on. I keep those going because there's good rationale to think that there might be less risk for cancer, and they're generally well tolerated.
Mm-hmm. And have you seen patients still flare with GI problems whilst on LDN?
Yes, and people can flare for a variety of reasons. I mean, people can flare, when they're on a good dose of, let's say they go into remission on a 5-ASA medication, the standard first step for most patients, where 67% get into remission after 6 to 8 weeks. Well, after a year, there's about a 10 to 15% flare rate. And we don't always know what is triggering it, but it can occur, and then you can treat them and increase the dose and recapture remission. So with respect to naltrexone, you look for other triggers. Perhaps there's been some trigger with respect to the bacteria, so you could add a probiotic. Rethink the diet. And yes, somebody asked about stress. Stress is bad for every gastrointestinal disorder. Every single one does respond to stress in a real way.
Mm. Stress certainly isn't good for you, is it? In lots of different ways. We have a question. Phyllis, who's our head admin on Facebook, she says, a very common question, and could you address it? She said, how common is it to have a true Herxheimer reaction? What conditions are most likely to produce this reaction? And at what point in LDN treatment is a patient most likely to experience this response, in days, weeks, or months?
I don't find that to be, it's an immunological reaction. I don't find it to be a significant problem. So I'm not sure, what exactly they're experiencing, but I don't see it.
Okay. Well, we'll just have a quick break and we'll be back in just a minute. Thank you. Full details of the 2017 Integrative SIBO Conference and Professional Forum on Saturday and Sunday, March the 25th and 26th in Illinois can be found at www.synergy-cme group.com/2017-integrative-SIBO-conference. We hope to see you there. '17 Special offer from Chelsea Green Publishing. Free shipping for US non-bookstore retailers on orders of 25 books or more. For full details, email me, linda@ldnrt.org. Okay, welcome back. You were saying, Dr. Weinstock,
that the question, I was a little confused about the question, whether LDN causes a Herxheimer reaction or antibiotics. And if we're talking about antibiotics, then the answer is yes. The common name is die-off, and if you've got a high bacterial load, treating with the antibiotic will cause odd symptoms, flu-like condition from toxins getting absorbed through the fact that there's increased intestinal permeability. You're killing off bacteria which are invading, and some of those toxins get in and give you side effects like a bad flu. Mm-hmm. But LDN doing it, no, because LDN does not kill bacteria.
I think that is the question Phyllis was trying to establish. Is there are a lot of people saying that LDN does cause this, but you're saying in your experience it doesn't happen.
Right, and by definition it doesn't make sense that it would. Okay,
that's a good question to address and, as we say, put to bed. That's a big help. Thank you. We have some really interesting questions here, and we had one from Elizabeth, and she says, "Hi, Dr. Weinstock. I'm so glad to hear that you were going to be on the show. I've had major food sensitivities, gastroparesis, and what I now believe is probably the more difficult version of SIBO. I also suffer greatly from Lyme disease and CPRO poisoning. LDN eliminated so many of my GI issues, and I was able to eat again for 1.5 years on it, until recently I re-poisoned myself with an antibiotic. I'm rapidly losing my ability to tolerate food at all due to my GI symptoms returning after that. Are there any changes I need to make with my LDN in order to jumpstart it working again? Thank you."
Interesting. So there is autoimmune gastroparesis, and there are autonomic disorders that cause poor small intestinal motility. So there may have been a change in the immune system triggering off this condition. One thing that I would look at and ask your doctors to check out is a condition called POTS, postural orthostatic tachycardia syndrome, a very intense, tricky disease for many people. About 1 million are affected in America alone. So that can be something that fluctuates and can need aggressive therapy, and we're actually looking at immune globulin given intravenously. I would also, if there's a disturbance of bloating, I would again look for small intestinal bacterial overgrowth. It's rare, but it can be reported that taking antibiotics can trigger somebody to have small intestinal bacterial overgrowth. It kind of goes against your frame of reference and sense, that common sense, but multiple courses of antibiotics somehow can affect it, and perhaps you're killing some of the few good bacteria that keep the small bowel immune system in balance, and then the bacteria that are colonic or anaerobic come up, and then it can attach because we lose good cytoprotection.
I mean, she does say that she recently, and she's put here, re-poisoned herself with an antibiotic, because antibiotics, in my humble opinion, just kill bacteria, good and bad alike. It doesn't differentiate between good and bad. And I have been told that you should take probiotics after an antibiotic to help build up the good bacteria. Am I thinking along the right lines here?
I think that's very, very good. Yeah, Lactobacillus GG taken with an antibiotic can prevent complications.
Taking it with it, not after.
Yeah, Lactobacillus
right.
GG, has been looked at. There's a study in children for that, and then of course taking it after couldn't hurt as well.
Mm-hmm. You see, I would have thought if you're taking an antibiotic, it would also kill off the good bacteria that you're taking.
And that's the common thought, but for one reason or another, the Lactobacillus does okay and is helpful. So that's been one of the few studies that has helped show that it decreases the risk for diarrhea after antibiotics in children. That's the one study that was done.
Okay. We've just got time, I think, to answer Tracy's question. It's in 3 parts. She says, I am due to have an SEHCAT bile study, MRI in nuclear medicine department. Should I stop taking LDN before ingesting their solution? That's question 1.
Well, let me just say no to that. Really, the only issues with LDN is taking it in somebody who's dependent on narcotics, because you definitely can cause a withdrawal reaction.
Okay. Question 2. She says, my GP tried to suggest LDN is lowering my white blood count. I started taking LDN. Now, depending on where she lives, she's put 090216. To me, that would be the 9th of February, but to you, that might be the 2nd of September. So I don't know. My WCP prior to that date was 3.1. The next 3 tests, it started to improve to 3.4, 4.2, then 4.1. It's only my last test that has dropped to 2.9, the lowest ever. I have a number of symptoms, including swollen lymph node, night sweats, breathlessness, and elevated IgM. He is sending me for an ultrasound. I'd like to assure him that as I've read the patient information leaflet for 50 milligrams of Naltrexone, there is no evidence that it causes low WBC. So how can taking 2.5 milligrams be responsible for it? Am I correct in this? Am I explaining it in a bad way? I just want to reassure him not to worry, as he thinks he's seeing a bad light for taking it. She's talking about the LDN there.
Okay, let me address that. So the only thing that has been seen in drug studies in normal doses of naltrexone is an elevation in the liver chemistry when it's at 300 milligrams. But we've not seen any disturbance of the bone marrow. So there's actually probably no difference between a 3.1 and a 2.9 statistically. So she's fluctuating, and maybe the rise of the white count creeping towards normal was due to a beneficial effect of LDN if there was an autoimmune basis. So again, I would say there is no relationship to what the white count is.
Okay. Question 3. My calcium levels seem to have crept up since starting LDN. It has now been known to do that, and there is no specific blood test that I should be monitoring.
Well, I'd want to know what the protein or the albumin level is to put that into perspective. If it was truly, let's say the albumin level was low and her nutrition improved, the calcium levels would rise. If, however, the calcium levels were in the high range, I would worry about the parathyroid glands, and I would get what we call a PTH, parathyroid hormone test. But I don't think that's related to the LDN.
A question that's always asked, and I think I know the answer to this, what are your views on using LDN and steroids?
Well, I do have patients who are taking both who have severe inflammatory bowel disease, and then that's the one drug as soon as the LDN's kicked in that I taper off the steroids more aggressively. So, it's been brought up by some pharmacists that, will the LDN work if somebody's on steroids, or will it work if they're on, let's say, pyranethol, an immune modulator? And I think the answer is yes. The immune modulators and immune suppressors do reduce the activity of T cells and B cells, but indiscriminately and probably more than it should for a healthy person. But the LDN also is responsible for regulating and reducing the bad T cells and the bad B cells that are overworking and giving us autoimmune diseases.
Mm-hmm. Didn't Dr. Jill Smith use LDN in conjunction with steroids in one of her trials?
Yes. So she did not stop them. She used it as add-on therapy, as I do, and hopefully it'll be what we call steroid-sparing activity that will help our patients get off of prednisone.
Is there a limit to how high you would go with a dose of steroids and LDN?
No, I think they're independent. I hate bringing anybody higher than 40 on prednisone by oral route. When somebody comes in with a severe attack of inflammatory bowel disease, yes, I'm giving Solumedrol at very high doses, 60 milligrams 3 to 4 times a day. But when that's going on, we're trying to get things under control so they don't go to surgery and have colectomy.
Mm-hmm. Well, that's all the time we've got for questions, unfortunately. We'll have you back again soon. We'll have a really good question and answer session. So I'd like to thank you very much for being with us and sharing your experience, and it will be amazing to have your lectures at the LDN conference. What conditions are you covering at the conference this year?
Okay, well, you've got me set up for a number, two in person. So we're going to be talking about POTS, and celiac disease, irritable bowel syndrome, and inflammatory bowel. And so it's a lot, and I look forward to it. A couple of them are going to be done basically as podcasts with the slideshow, and then people will be able to call in questions during the conference.
That's right.
And then,
this was the good thing with how we have the conference. You'd be surprised at the number of doctors that say that the lectures are fantastic, absolutely amazing. But what they learnt more was when it was the questions and answers. One lady said, Doctor, she really enjoyed the questions and answers. People asked questions she would have asked if she'd thought of them. She had her questions answered. And what she really enjoyed was the fact that if there was a question put to the panel and they didn't know the answer, they weren't embarrassed to say, no, I don't know that. So she said that gave it credibility to the answers, to the questions that were answered. So that was a nice compliment there. And the number of questions we get through in those questions and answer sessions is amazing, isn't it?
Yes, and I thought it was good going up and down on the podium and the table with 5 different experts or experienced people and trying to tackle tough questions. Of course, many of them we just don't know, we don't have the experience. And that said, I just would encourage the prescribers to keep track of their patients so they can present the data, and because that's the only way we're going to know, and we'll never really know until we do double-blind studies, which it's going to be hard to do because of the fact that there's no funding for anything related to a compounded generic medication.
And that isn't going to change anytime soon, really, is it?
No, unfortunately not.
So what's your...
But I think that people can spread the word, and people can get better, and patients can get better, and doctors can learn. But there's some big roadblocks getting doctors to prescribe LDN, and I'm glad that you list the doctors that do prescribe. And I know there are some that will even do phone conversations or FaceTime with people to give consults and give advice.
Yes. Well, our time is up. And once again, thank you very much.
My pleasure.
Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well. Full details of the 2017 Integrative SIBO Conference and Professional Forum on Saturday and Sunday, March the 25th and 26th in Illinois can be found at www.synergy-cme group.com/2017-integrative-SIBO-conference. We hope to see you there. The LDN Research Trust has its own forum, which can be found at forum.ldnresearchtrust.org or via our website. The forum is divided into sections, so it's easy to navigate and find what you're looking for. You can share your experience, ask questions, keep a journal, etc. Unlike Facebook, the posts are always easy to find and don't get buried. We have a private medical professionals only section. To find out more, please email me, Linda at ldnrt.org. (2017) special offer from Chelsea Green Publishing. Free shipping for US non-bookstore retailers on orders of 25 books or more. For full details, email me, Linda at ldnrt.org. The Lyme disease documentary. Please can we ask for your help and support? We've been trying to raise funds to produce our documentary on Lyme disease. We want to explore all the elements of this controversial disease and to produce a documentary film and an expansive educational resource where all interviews are published. We are almost there, but we still need to raise a further $10,000 to make it the best it could be.
The best description that I've ever heard of Lyme disease was a patient who said, Lyme disease doesn't kill you, but it does take your life away. And I think that sums up how it feels for most people. I don't think there's anybody who's lived for a significant length of time with Lyme disease who hasn't wondered if they would rather be dead.
Please can you help by making a donation today at www.ldnresearchtrust.org/Lyme. Every donation, however small, really helps. Thank you in advance. Dr. Jill Smith and Dr. Leonard Weinstock co-wrote a very interesting and informative chapter in the LDN book on inflammatory bowel disease.